Perfect. So I'm a fast talker, as Nico and Nicole and others know. So please feel free to interrupt me at any point with questions or thoughts you might want to share. So uh, hopefully this is going through now. So there we go. So I want to start first by talking a little bit about the public health challenge around rare diseases. We know that there's over 10,000 different types of rare diseases, but only 5% of these have cures. The time that it takes to develop from basically the start of in like a basic lab to ultimately a medical cabinet is really between 10 to 15 years on average for many medical products. And 9 out of 10 promising therapeutic candidates eventually enter clinical trials only to fail. So this paints a general picture of some of the issues that we talk about around rare diseases and rare diseases research. And this is partly why a lot of the work that we tend to do within the NIH, focusing specifically on rare diseases, it's across all of the different institutes and centers, but specifically at our Translational Science Center, rare diseases have a very big focus. So I'm with the National Center for Advancing Translational Sciences, or NCATS, and our mission is to turn research observations into health solutions through translational science. And part of what we try to do is we focus on several different approaches, two of which I'm going to focus more on in my talk today. We often target similarities or commonalities across diseases so that we can look at either research leading to multiple treatments at a time or efforts that can be basically used across in multiple diseases in common. In addition to these other principles, the last one on the right-hand side, we oftentimes are focusing on public health needs, thinking about real-world data, data science approaches, and how that can help solve some of these challenges. Specifically for rare diseases, we oftentimes will describe that at the NIH, specifically for NCATS, NCATS is really has a home for rare diseases. Part of that is because that one of the things that is in common amongst many rare diseases are that they see translational science roadblocks to them. I'll go over that in a little bit. Two of the areas that NCATS focuses on in rare diseases basically are kind of where my portfolio extends to, which is one, resources to educate, engage, and empower the rare diseases community, and two, data-driven solutions to help with issues such as the diagnostic odyssey or economic burden of rare diseases. So what are rare diseases? Rare is a legislative definition. When we talk about rare diseases, we're talking about individual countries and how their legislative bodies have defined a rare disease. In the US, we define rare diseases using an absolute prevalence number, less than 200,000 people in the US. This comes from the 1983 Orphan Drug Act. And I highlighted one part of that act in particular in that the law itself was really about trying to incentivize development of drugs to treat rare diseases. The issue behind this, if you're not familiar with rare diseases research, is that oftentimes because rare diseases are rare, because they don't affect large populations, one of the hardest things with seeing research really develop across these different rare diseases is that you can't make a really convincing business case. If this is a disease that really only affects less than a dozen people in the US, why invest in research and development, knowing that it takes 10 to 15 years, knowing that 9 out of 10 trials will fail? So part of how we tried to basically incentivize drug development was really around the Orphan Drug Act and starting to identify what rare diseases are. Again, this is different in different countries. We use an absolute prevalence. I much prefer personally prevalence rates like what the EU uses. Part of the problem with that is that our overall population in the US has changed and grown over time. So when the law first came into act in 1983, 200,000 in 233 million was roughly less than 8.6 in 10,000 people. Today, population has grown to closer to 334 million as of last year. That's a ratio, it's closer to less than 6 in 10,000. So there's a lot of diversity when we're talking about what is and isn't a rare disease. Some of that extends to both country and what you use to define that, and some of it extends to the fact that some of these numbers shift over time. When we look at individual rare diseases and how they're defined, I like to kind of describe it as it's a use case definition. This definition here described on the left-hand side is from some of our colleagues, Rare Diseases International, in presentation they did to the WHO. Disease is a known pattern of signs, symptoms, and findings with some type of underlying explanatory mechanism or etiology. It's a distinct pattern that develops over time. And that pattern also extends to how it responds to perhaps certain interventions. Many rare diseases have linkages to some type of underlying genetic factors or linkages to some type of interacting environmental factors. Now, in common, there are a number of different groupings when you talk about rare diseases that you see quite a few of them. Many rare diseases, as I was mentioning earlier, are genetic. Up to about 80% have some type of genetic, suspected or known genetic cause. A number of rare diseases are affecting the nervous system, and many of them also affect development and are perhaps better defined as a congenital condition. In addition to that, there are quite a few that are cancers, but you also have diseases such as infectious diseases, toxins and exposures. So it's quite a heterogeneous grouping. What knowledge exists about and for rare diseases? This is one of the problems we see. Research knowledge for rare diseases is continuously growing. This is a slide that almost everyone always uses from OMEM, the Online Mendelian and Men database and resource. This is just showing you that over time, we know more and more about diseases and also more and more about the genetic underpinnings behind them. In addition to that, on the right-hand side, what you see are two different charts that just show you for a number of diseases that this study targeted, the growth in the number of publications over time. If anything, this has continuously gotten higher and higher for many rare diseases in the last several years as well. Now, for me, my interest is really around patients and consumer health information, how people look for information and what they do with that. Where do patients with a rare disease or people living with a rare disease look for information? This is one survey that was done, and I wanted to pull your attention really to a couple of things. The, the way that people look for information has changed over time. People may in the past have heavily relied on perhaps television, radio, or maybe their individual experts or providers. Last coming several years, there's been a democratization of information. More and more folks are making use of the internet, of websites, of crowdsourced Wikipedia pages, of now chatbots to really look for information. So the patterns that we're seeing of how people are looking for information are shifting, and if anything, are growing in terms of options. In addition to that, how do people use that information to make informed decisions? Can we support patients in making informed decisions? This was something I was recently thinking a lot about because one of the grants that we were, programs that we were working with, we were providing funding for a research group to basically provide free diagnostic support services for folks that were suspected to have a genetic disease. So they basically would have expedited access to a medical geneticist and a basically whole genome sequencing. Now, a number of people actually declined access to that, despite the fact that this program actually utilized an algorithm to try to figure out if there are certain individuals that have basic phenotype features, utilization of healthcare, and other factors suggesting that they likely have a rare disease. This is something similar you see oftentimes in literature as well. So these graphs here are from a study that was a survey that was done with ALS patients, basically looking at if you had ALS, would you be seeking out genetic testing? And this was done internationally across several countries. And it was really interesting because you could see some of the differences in terms of both how different countries, maybe our individuals from certain countries were receptive or not to the idea of seeking out genetic testing. But also they added in this extra layer where they provided basically these little diagrams below to suggest, hey, is this something that would be a greater risk if you had a family history of suggestive of ALS? And they compared that with both patients as well as with clinicians. So part of our questions here about rare diseases, about information, are really about ultimately how do we make that information accessible and usable by people living with rare disease or suspecting that they have a rare disease. And one of the things I wanted to do in this, hopefully, was it too fast, overview of some of the background information was to give you an idea of some of the bottlenecks and challenges in this space. So within the Translational Science Center, again, NCATS, we oftentimes really heavily focus on thinking about these bottlenecks. Within this consumer health space of, and I'm getting a warning of my battery being low, so give me a minute. Within one of the major issues within this area is really thinking about some of the bottlenecks in consumer health information and access to information for rare disease patients. So I really wanted to focus on three issues that hopefully you were able to see from the background information I just shared. One is that the range of topics covered when we describe rare diseases is quite voluminous and heterogeneous. We're talking about over 15,000 the diseases that really cover hundreds of classification types and require a diversity of both specialists as well as experts to really help assess. So there's really no way to be an individual specialist in every rare disease possible just because of that. The knowledge that is, the research knowledge that's being created about different rare diseases continuously grows and is quite variable. You have diseases that range in their evidence base from just a few case reports to those that have maybe decades of publications, longitudinal trials, systematic reviews, meta-analysis, you name it. So really quite a variety. And then lastly, consumer health information seeking behavior has changed over time and continues to evolve. Where individuals might have access to libraries or contact centers, they're switching increasingly to internet searches, crowdsourcing, and new ways to navigate information like chatbots. So really, we're in a quite complex space with this all. Any questions or so far? Okay. So when we talk about the public health challenge of rare diseases, two things I want to focus on. So again, we're talking about over 10,000 different diseases. The average time to diagnosis varies in different surveys and studies, but generally it's somewhere a range of 6 to 8 on average. And there are a number of different factors that really are concerning about this diagnostic process. In fact, oftentimes when in the rare disease research space, we refer to this as the diagnostic odyssey. It's quite costly. This report, this infographic you see here is from a report by the Every Life Foundation that just describes some of the costs involved in diagnosis and management of different rare diseases. And when we talk about that diagnostic journey itself, that odyssey, there are a lot of commonalities around it. So this patient journey map you see on the left-hand side by the National Organization of Rare Diseases, or NORD, was originally developed by a group within the EU, Eurodis. And what they noted was that many patients start their journey with perhaps their primary care provider or general practitioner mentioning the suspicion about a particular rare disease. And that's oftentimes where a number of people with rare diseases start to then interact with some of the programs I support, is when they start going online and making a search. So one of the programs that I manage is a program called GARD, or Genetic and Rare Diseases Information Center. It's almost 2 decades old now. Originally started as a contact center, later developed a website, and it generally tried to answer general questions about rare diseases and help individuals that were trying to navigate healthcare systems, looking for a diagnosis and looking for support. One of the problems that we have is that there's a lot of existing knowledge out there, but it's hard to untap and kind of make use of in consumer health. So these are different types of information, for example, that we're oftentimes looking for. Signs and symptoms or clinical features, clinical course, the age of onset, the history and change of disease over time, the etiology or cause, the types of medical specialists that can help with diagnosing it or managing it, and simple other facts such as population estimates. Again, I already mentioned one of the problems being that new research information is constantly published and updated. So as an example, on the bottom left is a graph of publications by year for Ehlers-Danlos syndrome, a very more highly prevalent rare disease. And overall, there are over this, as of when we did this a couple years back, about 160, but I want to say there's 160,000, but they're probably a much, much larger number now, since it's been several years in terms of publications. The other main problem being this research information can be hard to access, retrieve, or interpret. There was a slide I showed earlier where a number of people were looking for information from publications. It's hard to read publications. You have to have a good biomedical background to really understand a lot of the terms used. And even to understand information about specific disease requires a lot of understanding of research processes and kind of how that information is gathered. So there are a number of different databases and knowledge sources that try to organize that information. This graph on the right-hand side is from HPO. I'm going to use a couple just because I feel this is a good chance for me to show off some of the work that Nico and Nicole and others have done. It's hard to still look through that and try to understand it, even from either a clinician or a researcher's perspective, because there's just so much information that's out there. So part of our focus in thinking about these challenges is really looking for opportunities. Two of the principles that we utilize in translational science that I really want to focus on. One is generalizable solutions. Can we create solutions that can address many diseases at a time? Something obviously really pertinent within rare diseases. The other is focusing on unmet needs. Can we build on existing knowledge, explore and address unmet needs patients are facing? So we already discussed one major unmet need, the diagnostic odyssey. The Government Accountability Office for within the US has generated a report a couple years back that basically talked about the diagnostic odyssey and tried to focus on a couple of different problems here. I'm going to try to focus on two groups of these. There are a number of different common healthcare experiences that people living with a rare disease will oftentimes experience. For example, they will oftentimes meet providers that lack knowledge about their disease. One of the stories that you might often hear from rare disease patients is that they'll oftentimes have binders that they'll come in with or folders that they'll have set up to provide new providers, new clinicians that are working with their child or themselves information to understand the disease. So oftentimes patients and caregivers can be more of a expert in their disease than clinicians may, just because of the lack of knowledge amongst providers. There are oftentimes access difficulties. So one of the more common findings in several of recent studies around the diagnostic odyssey has been around distance as a factor in the time it takes to a diagnosis. So a couple studies coming out from Spain, for example, showed that the further you were from basically urban centers that had major medical centers and tertiary care or multidisciplinary care teams, the longer your diagnosis basically could take. Similarly, one other issue that's in common for many rare disease patients is misdiagnosis. A number of different surveys have shown that oftentimes patients have been given several diagnoses before they get to a correct one. In addition to these factors, again, relating to healthcare, there are also characteristics that are in common in the diseases themselves, amongst many rare diseases. A number of them have disease presentations that cross multiple systems. Some of them may have symptoms and signs that overlap with other diseases. Frequently, especially for diseases that lack research understanding, there may be a lack of available or accessible diagnostic tests. And then lastly, rare diseases oftentimes don't happen in a vacuum. You may have other comorbid conditions. Sometimes some patients have multiple rare diseases together. So what we're trying to look at as translational scientists in these different factors, these commonalities, are opportunities. So in going back to those two principles, generalizable solutions and unmet needs, if we think about within generalizable solutions, one of the strategies that we're trying to focus on in rare diseases and thinking about public health information is really trying to describe best practices for patients that are navigating this diagnostic process. So some of the actions that we're interested in are trying to support when and how to get referrals for medical specialists, when and where to escalate their diagnostic evaluation, how to find experts that understand particular disease, and lastly, when to consider a second opinion. Again, all of these are common experiences within healthcare experiences that patients will face. Similarly, in terms of thinking about that focus on unmet needs, what we're trying to do is also look for and disseminate reusable knowledge that is common to diseases in a grouping. So for example, there are key decisions that must be made if you have a genetic disease that has some type of causal genetic variant associated with it, then likely there may be a question about when and how to get access to genetic testing. Similarly, you may be looking at unique knowledge that's specific to a single disease. Is there things that we can do in common to make it easier to collect that? Are we looking for awareness about a particular type of publication? If there's a disease that's moved from case reports to now having clinical trials, are we looking for the presence of a systematic review or meta-analyses? Are we looking for a natural history study? Are we trying to see if a disease has clinical practice guidelines? Similarly, how do we identify experts in individual diseases? Are we looking towards an intermediary like a patient group? Are we looking at the publications or clinical trials and the PIs associated with that? Are there ways that we can try to devise common approaches to getting the specific type of information? These are things that are of interest to us in the space of rare diseases. So going back to the program that I manage, GARD, Genetic and Rare Diseases Information Center, this program basically was charged with trying to provide understandable information on rare diseases. And I kind of look at it as it's a public health resource supplying consumer health information specifically to people living with a rare disease. So we try to really focus on three principles in thinking about how this program is trying to operate and the types of information we're trying to address. One is around knowledge management. There's a lot of information out there. We don't want to be redundant. We don't want to duplicate it. One of the things I hate is that a lot of different folks will end up writing a description about a rare disease, and it's basically the same type of description written multiple times across multiple programs instead of trying to see if there's a way that we can just share and kind of reuse work that others have done. So we try to follow principles such as COPE, create once, publish everywhere. We're looking at ways that we can make scalable and sustainable knowledge rather than trying to, again, just think about one-offs that we would have to manage. We're focused heavily on health promotion. So a major principle behind that is health literacy. What that means is that we have to make sure that the information that we're generating is actionable and meaningful for public health use. Focusing specifically on maybe a task that a patient or a person that suspects they may have a rare disease is trying to perform. And we want to try to leverage evidence-informed practices as much as we can, especially when we're looking at needs that a patient or caregiver may have in rare disease space. And lastly, as part of that, we focus very heavily on human-centered design and thinking about the user experience. We want to make sure that we account for the patient and caregiver journey, how they're looking for information, what are the major decisions they're trying to make, and the needs that they have for information. So when we oftentimes talk about rare diseases, one of the seminal papers that I always point to is, again, something that Nicole and others and Nico and others have been involved with. There are a number of different resources that exist around diseases, ontologies, specifically, as well as other terminologies. This paper pointed to over 10,000 different rare diseases, but up to about somewhere in the range of between 2,000 to 6,000 shared across these different resources. So one of the things, again, we're trying to focus on is not reinventing the wheel. We like to look towards where we can find existing sources of knowledge already. For rare diseases, again, I'm just pointing to several here, in addition to Mondo. And then in addition to that, there are resources across the NIH and at large that cover both common and rare diseases. Much of what we try to do is see if we can distribute and disseminate information from these existing resources. So we try to look for ways to identify public health needs. So as an example, again, focusing on the rare disease diagnostic odyssey, we know it takes a long time We know there oftentimes are a lot of specialists that will be involved in terms of that diagnosis. And then we know in terms of particular disease groupings within rare disease space, example being mitochondrial diseases, the type of specialist is something that has already been identified by a number of groups. So example would be, this is one paper with some of the research networks that we support in some of our grants that looked at who was the first doctor they were a patient might have seen with a mitochondrial disease versus who was it that ultimately ended up creating that helping them with that diagnosis. And oftentimes it's more of a specialist like a neurologist or geneticist, a metabolic disease specialist. So this information is useful for us because what this tells us is that when we're then thinking about this big grouping of hundreds of different diseases, mitochondrial disorders, likely there are some patterns here in terms of thinking about diagnosis. So one of the ways that we try to leverage that is using existing knowledge sources to help us create answers for that. So for example, one of the ways that we make use of Mondo is mappings to other knowledge providers such as Orphanet. Orphanet is a really great resource. It's focused on rare diseases, but also specifically they're looking at rare diseases from a very clinical perspective. One of the things that they did when they generated their ontology was they generated their ontology with a focus on their groupings were really about what type of clinicians, what types of specialists are basically going to be the specialists that would help evaluate, or diagnose, and manage a particular rare disease. So when you look at some of their groupings, like rare tumor, for example, we know that we can trust some of the curators from there, that when they're looking at disease and they've classified it as a rare tumor, that they've also basically told us that this is the type of disease that would be managed by someone like an oncologist. So we look at their concepts and we try to convert those into public health needs that content can help fill. So for example, again, medical specialist, we try to describe what an oncologist is. We try to then provide links to where to find specialty centers for cancer centers or directories for oncologists. This is part of the way that we try to make use of existing knowledge. I'm going to go over a little bit in detail of this now, just to kind of show you some examples of knowledge repurposing. So one of the major reasons why we make heavy use of ontologies is really around transitivity. So in our use case, what we're thinking about, again, is you have a disease. It connects to certain groupings by a particular ontology, in this case, Orphanet's disease ontology, let's say. So we have rare tumor. Again, we connect that to a content task. Here's a recommendation around the type of medical specialists that can act as a diagnostician for this disease. We use that connection to then think about content that a user needs for action. So for a patient, we then think of here's a directory for where you can find those oncologists. But in addition to that, we want to think what's next. So the first step might be to see an oncologist. Okay, great, they have you evaluated. Maybe you need a second opinion. Where do you go next? Now, one of the problems we have is that there's a lot of oncologic groupings. So within the tumor space, there's quite a few. Orphanet has in Ordo close to 900 different tumor concepts. Those are broken down into different classes, as you see here. Some are smaller, 18 for rare eye tumor, 112 for digestive tumors. Now, which one of those makes sense to create content for? This is where it's a little difficult. We go back to this other slide, and part of what we're trying to figure out is action again. So unfortunately, not every tumor grouping can we connect to some type of directory for, let's say, a medical specialist. Here are three I can find in particular that were listed by the American Cancer Society, American Brain Tumor Association, Society of Gynecologic Oncology. I keep saying ontology, oncology, sorry about that. Society of Urologic Oncology. These, again, are resources that exist that are valid, that are sponsored by professional societies for finding specialists. That gives us an idea that even though, again, there may be large numbers of groupings available, unfortunately, not all of them can be connected to content. So part of what we're trying to do in our consumer health focus is really think about, again, what is actionable content, even if we have the grouping classes in an ontology. we may not be able to connect it with usable content for an end user. So part of what we try to do is look for ways to systematically make those decisions. So that's one way that we try to use ontologies. Another way is actually reduction. So I love the Human Phenotype Ontology HPO. We use it on our website and our internal systems as well. Orphanet and OMEM have helped curate basically thousands of diseases with phenotypic features. Now, some of our staff from the GUARD program in the past have helped create basically plain language synonyms for a number of different HPO concepts, but not every HPO concept has a plain language synonym. So part of the problem we have is, as an example, again, just focusing on Orphanet just because I mentioned it once, so it's easier to kind of continue this in the presentation. There are close to 8,000 different phenotypic features, HPO concepts, that Orphanet has curated and associated with some type of rare disease. About 4,000 diseases or so we've connected to with our database. This ranges from some concepts having 2 phenotypic features to up to 187. So part of the problem is the number. The other part of the problem is the specificity and granularity of the concept. For example, for seizure, in HPO, there are close to 346 different types of seizure or descendant nodes of seizure. These get increasingly more granular. So for example, you move from seizure to bilateral tonic-clonic seizure to then bilateral tonic-clonic seizure with generalized onset. In Orphanet data, there are roughly around 60 different seizure subtypes associated with about 340 different rare diseases. And you can look at some of the terms here. Again, difficult for a provider to understand sometimes, let alone a patient. Quite granular in terms of their scope. And again, that makes sense from the purposes of what HPO is trying to do, as well as what Orphanet is doing in their curation. For a clinician, you have to be granular. The more granular you are, the more specific and detailed you can be, more accurate you're able to make your assessment. That's not necessarily what a patient's looking for. That's not also as helpful to a patient sometimes, if that level of granularity. So what we try to do is use principles of reduction. So we then try to create tags for different HPO concepts. And this is still behind the scenes. We actually haven't started using this yet, but this is kind of our current plan is by tagging certain HPO concepts that are parent nodes. What we then try to do is we basically roll up these concepts to the parent. So rather than seeing this more granular terminal leaf node, what we do instead is that every instance of that terminal leaf node, we try to replace it with the more, how do you say, plain language and more broader concept seizure. For a patient level, that makes it easier to both understand, but also think about connections. So what we then try to do is really focus on that connection, that content that we want to connect to, that ultimately we're delivering. So for a number of different diseases that are associated with any type of seizure, ultimately what we're trying to do with that is not just a description of what seizure is. We're really trying to think about how can we connect that disease and a patient looking for information about the disease to understanding that if they are concerning for having symptoms like a seizure, or if they are looking for what concerns might have for that disease in the future. We want to disseminate information that already exists. A number of our colleagues have already created plain language consumer health content on epilepsy and seizure that we want to try to share. We want to promote the patient communities that they may be able to reach out to and try to connect with other patients. So for example, the Epilepsy Foundation. And most importantly, we also want to make sure that it's clear if they are having a seizure, where can they go next to start, again, pursuing more of a diagnosis for this underlying condition they may have. So we want to make sure they are aware of resources such as National Association of Epileptic Centers, where they can find directories for additional specialists. That's the way we try to use the information, is not at the level of clinician, really thinking about what is useful for patient action. one of the things I kind of want to mention before I start to wrap up here is that there's a lot of barriers to health information usability. There's literacy and numeracy. There's information literacy, finding, locating, and searching for and evaluating for information. Scientific literacy, even being able to understand ultimately what goes into like a publication if you wanted to access that. We're very heavily focused on health literacy, which basically tries to leverage components of all of these, as well as computer literacy, internet literacy. This is really about the acquisition, evaluation, and application of relevant health information. So that's really a big focus for us when we think about issues in health, consumer health content. The overall approach that we're trying to use to build our systems kind of looks like this. And this is more of a complex slide to just give you an idea of what we're trying to do in our internal systems. We have a larger informatics pipeline where we basically have utilized Mondo as one of our supersets to help us with mappings to other knowledge sources so that we can start to pull in and kind of make use of information from them. This information is something that I'm trying to use in the GUARD program, but also hopefully other NCATS programs as well. Within the GUARD program itself, then what we're really trying to do is we're leveraging basically the data model of Mondo and other ontologies to help us with modeling some of the semantics about these different diseases so that we can then connect that to content. And all the stuff that we're doing downstream from there in terms of thinking about content authoring and managing and delivery are really about focusing on what the end user, a person living with a rare disease, prospective patient or caregiver, what are their questions and needs, and thinking about how we can transform information to fit a task that they may desire information to help with. So that's really kind of how we try to integrate and make use of information from ontologies like Mondo and HPO. I'll end this with the last couple of slides, just noting that this is something that our program doesn't do alone. A number of different information programs within NCATS make use of Mondo. So programs such as Pharos, which focuses on targets, as well as some of our other groups like Translator, which is not listed here. The last thing I'll kind of note is that how that then kind of operates is that we are using really ontologies as a layer to help us connect to data that we can repurpose and reuse, knowledge that we can then share across different multiple diseases, and then ultimately think about content that we would then push out to something like a website. It's a vital part of this entire lineage, which is really why Mondo is an HPO or incredible resources that have a lot of potential. And again, that's kind of how, at least with this program, I'm trying to tap them for use. So hopefully that wasn't me talking too fast at you, but again, just wanted to give you some highlights of some of the work we're doing and an understanding of the principles behind what we're trying to address with consumer health informatics and rare diseases, as well as ultimately how we try to leverage resources like Mondo.
Eric, thank you very much for taking the time. It was really great to have you here. It was super informative, super interesting, and hope to see you again at some Mondo outreach call soon. And yeah, talk to you soon.
Yeah, thanks
Bye,
for having me.
everyone else.
Thank you.